Hernandez.
Thank you. Let's go to move to item number 1. Is there a motion? So moved by Senator Wogt. Item number 1, AB 50, due past appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Wen. Wen, aye. Hall. Hall, aye. Mitchell. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye. 7.
Currently has 7. It's enough to get out. We have an absent member. We'll place that bill in call. Item number 2, AB 176. Is there a motion? So moved by Senator Woke. AB 176, due passes amended appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Wen. Wen, aye. Hall. Hall, aye. Mitchell. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye.
7, we'll place that bill in call. Consent calendar, item number 8. Is there a motion? So moved by Senator Hall. Due pass, just item number AB 580, consent. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Wen. Hall. Hall, aye. Mitchell. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye. Wen, aye. 7.
Currently has 7, enough to get out. We'll place that bill in call. We're going to move on to item number 7, AB 521, Nazarian HIV testing. Good afternoon, Assembly Member.
Good afternoon, Mr. Chair and Senators. Approximately 16% of Californians who are HIV positive do not know they are HIV positive and are not receiving treatment and unintentionally exposing others. This percentage rises to 58% for people up to the age of 24. The 20,000 Californians who do not know they are HIV positive are causing 70% of new infections in our state. In an attempt to identify these individuals, this bill, AB 521, requires an HIV test to be offered to a patient upon admission to the hospital from the emergency department. This bill does not mandate across-the-board testing. It simply requires the test to be offered if blood is being drawn and requires the patient to consent to the testing. If the patient does not consent, then no testing will be administered. There are more than 5,000 new HIV infections in California each year, and this bill will bridge the gap in lack of HIV testing by continuing to focus on patients admitted via the emergency department. Emergency room trigger is key as emergency rooms continue to play a critical role in delivering primary care services to many new enrollees, to those who remain uninsured. With that, I have Rand Martin on behalf of the sponsor of the AIDS Healthcare Foundation with me.
Mr. Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation. If you read the press reports in the last decade or so, it would appear that we were getting ahead of this epidemic, as the statistics that the Assemblyman just recited indicate we are far from winning this war against HIV. And the way to win it is to make sure that we get to people as early as possible, get them tested, get them into care and treatment. So a report that just came out earlier this year that indicated that a person with HIV in care and treatment is 94% less likely to transmit the virus to somebody else. If we want to stop the spread of HIV, we need to get to people. There are large populations that we're not getting to, and many of those people use emergency rooms as their point of access to the healthcare delivery system. So we would like to take advantage of that audience and make the offers to them for an HIV test. It is only upon their admissions to the hospital, but we do think that there's a sizable number that we'll be able to identify, get them tested for HIV, get them into care and treatment if they are HIV positive, and get ahead of this epidemic. We urge your support. Thank you.
Thank you. Anyone else in support?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. We actually have a neutral position. We just want to take the time to thank the Assembly member, his staff, and the sponsor for their time and efforts in working with us through some of our concerns to allow us to move to a neutral position. Thank you.
Opposition?
Thank you, Mr. Chair and members. My name is Debbie Rogers. I'm here on behalf of the California Hospital Association. We want to thank the author and the sponsor. We think this is a very well-intended bill, and it could increase the number of people who know their HIV status. The problem with the bill is that it's an unfunded mandate on the healthcare system, and it's going to increase costs on the healthcare system, and it's going to increase the burden to providers, particularly hospitals and the clinicians that work inside our hospitals. So really what this bill does is it places the public health system surveillance function of surveilling the population for certain diseases. It mandates that hospitals do that function for HIV. And so in current environment, patients are tested for HIV, whether it's in the emergency department, in the outpatient, or in an inpatient, when the physician and the clinicians feel that there is a clinical and appropriate reason to test the patient. So there's lots of HIV testing that happens inside hospitals. But really, this creates a massive public health screening process in the 400 acute care hospitals in the state of California. So just to give you a little context of the numbers, there was 1.6 million emergency department patients who were admitted to the hospital last year through the emergency department. So that's really the universe of folks that we would be looking at. And approximately, according to the committee analysis, there's about 30,000 people in California right now who have undiagnosed HIV. So if we look at the people admitted through the emergency department and we look at the 30,000 folks that are undiagnosed, and assuming that's the same population, then that would mean that if we tested all 1.6 million people, we would find 18 individuals who had HIV. That assumes all 100% of the 1.6 million actually consent to the HIV test. If only 50% consent to the HIV test, we would find 9 individuals. And so this really creates kind of decreasing returns, and not to discount the individuals that are walking around today with HIV, but what it causes is hospitals to put together significant policies, procedures, training, quality improvement, all to meet the mandate. And it's cumbersome for hospitals because there's a large body of law that relates to pre- and post-HIV testing. It's not like the procedure for testing somebody for a vitamin D or for another thing that might be diagnosable on a lab test. And so all of that becomes quite cumbersome, including the law requires the medical care provider who administers the HIV test to inform the patient, ensure counseling, and do other things. So this sort of kind of structurally sets something up that the individual, I suppose, who draws the blood or orders the test, or I don't know what would be the one that would be responsible for all of the care, counseling, and coordination that the patient would need in follow-up to the HIV test, whether they're negative or positive. So in closing, we oppose moving this public health surveillance under the purview of hospitals, and for that reason, we're opposed to the measure. Thank you.
Thank you. Anyone else in opposition to the measure? Yeah, I believe Senator Hall, you had... No, okay, Senator Roth and then Senator Hall.
I just want to get some clarification on this because I try to understand all sides, and I was trying to understand the Hospital Association's opposition. When you talk about policies and procedures associated with HIV testing, aren't there some policies and procedures that need to be followed when you test inside the hospital when medically dictated? And are those procedures different than the procedures that you would use, the protocols that you would use to the extent someone voluntarily elects to have testing?
I think the actual policy of the test itself would be the same. I think identification of the patient, how all of this is documented in the record to reflect this mandate over and above what's in existing law.
Because, I mean, it's consensual, right? So you have to have consent forms, disclosure forms,
Correct.
And you do that whether or not the testing is done for purposes of medical diagnosis or for the purposes called for in this bill, right?
Right.
So is this a cost issue? Is it an unreimbursed test that we're worried about from a hospital perspective? I mean, I understand in the case of some hospitals, you know, you're underpaid and overworked, and some hospitals are in danger of going away. So we don't want to cause that sort of problem. Is it unreimbursed?
I think it could, and I'm I'm actually an ER nurse. I'm a clinician, not a finance expert. I think there will be circumstances where...
And I'm neither one.
There might be circumstances where it is reimbursed. There may be circumstances where it's not. I think the concern that we have is we have an inpatient patient who's quite sick to warrant an inpatient. The time spent on an HIV test is time not spent caring for other patients or that patient in other ways. Your point is well taken. The actual procedure to do the HIV test would remain the same. It's before you get to that. Is this patient admitted through the emergency department? How do we identify that? That's not something that is normally in the operations of a hospital. Is this patient an observation patient, which it might be cared for in an inpatient unit, but they're technically not admitted to the hospital? How to work through all of that to take this massive screening that will result in some diagnosis of HIV, but honestly not very many.
Well, with electronic record keeping, does it make it easier to sort out those that come in through the emergency room and those who come in for elective surgery, for example, not through the emergency room?
I think that's quite possible. We're seeing electronic health records as far as simplicity work both ways right now.
Okay, thank you, Mr. Chair.
So I may clarify a little bit, and this may also make it a little bit easier to understand. So in the bill, it says any individuals who have been admitted as an inpatient to the hospital through the emergency department and has drawn blood. So it's not like every single person that comes into the ER, they're going to ask them to do the HIV test. If they come in through the ER, they get admitted to the hospital and they happen to draw blood on them, then they're going to ask them, would you like us to do an HIV test on you? And at that point, then they're going to say yes or no. So it's not like, so with all due respect, I don't think it's going to be an additional amount of time because they're already going through that process. Now, I would obviously argue, as you would, with regard to the reimbursement. So if it's a patient that's not insured, then whether you're drawing the blood, you're still not going to get reimbursed. But there's a higher increase of Medi-Cal patients at this time, so therefore you're going to get slightly more reimbursement through this test as well. And I'm assuming that HIV is going to be a reimbursable issue. Senator Hall?
Yes, I'm just curious. You mentioned that there would be about 1 million folks that could potentially be screened if everybody who went to the hospital was absolutely screened, right? But everyone won't be screened because everyone going to a hospital or visiting a hospital won't have blood drawn, correct?
No, I was saying that everyone wouldn't consent to it. Not everybody's going to say yes.
And also everyone wouldn't get admitted.
That's
only when you're admitted and they draw blood once you're admitted that they would ask for the test.
Right. Senator, if I could clarify, it's the 1.6 million are the people who were admitted through the emergency department in 2014. So that's the universe of patients who would be asked if they wanted an HIV test.
So in your statement, you said out of those, perhaps maybe 18 would be identified as positive with HIV.
Yes.
Okay. And what would if 18 are identified early, would not the association and the hospital and Medi-Cal and all the other insurance companies save more money by identifying them earlier than perhaps later, and thus perhaps even infecting other people with HIV undetected?
Right. Yes.
So then wouldn't it be better then to check them earlier on the front end than to just not? And while you have them in a hospital environment where they could potentially be screened, might they otherwise decide not to go in to be checked for HIV?
Yeah, I think the point that I was making is that the public health surveillance function that's available, although not everyone avails themselves to it, on the outpatient basis is a more appropriate place to do the testing than on an inpatient hospital.
Well, where is the most appropriate, and when is it not appropriate to test a person for HIV if they're in a hospital environment where you have medical doctors and nurses? I would much rather be tested in a hospital than on a side corner clinic somewhere. I think a hospital, and by the way, all these clinics in our communities are doing extraordinary jobs, but I'm just saying that a preference, I'd want to be in a hospital where you have a doctor and a nurse and all the apparatus there to be able to provide service and treatment. So if the hospital is not the most appropriate place to be tested, where is the most appropriate place?
We think it's a public health function and an outpatient function, where the best case scenario, in my opinion, is when the person seeking the test has a relationship with a clinician in the community, a long-term relationship. They can establish.
I don't understand what's going on today, because I just left another committee where, poor people and are always getting the brunt of folks saying that they don't have time and service for them. And I don't know if it's just in the Capitol today. I don't know what it is, because those who are going to be adversely impacted the most, and who are most adversely impacted, are people in poor communities. And I saw the stats, and I know I've worked with AHF for the last 3 years on bills, and it's the poor people in poor communities that are at the tail end of treatment, of services, of access, et cetera, et cetera, et cetera. Now we have the California Hospital Association saying that they don't want to test people with HIV. I don't understand what's in the water around this place, but that just does not make sense to me.
Yes, Senator Roth.
Just to follow up, we clearly don't want to burden hospitals any more than we already have, and hospitals provide a valuable service in the state of California. Some are under siege, frankly, and financial and otherwise, and we need to make sure that we take care of that, because we do have a healthcare crisis. My colleague alluded to it in the state. In some areas, we don't have enough hospitals. In many areas, we don't have enough physicians or other healthcare providers. I sort of view this as sort of a wraparound obligation. Obviously, it's a good idea, and maybe the best place to handle this is community clinics and public health facilities. But there may not be enough of those. We certainly know where somebody has a physician, and the physician is counseling with the individual. But we know there's a physician shortage, and many of the folks, often economically challenged individuals, don't have physicians because they can't find them in certain parts of the state. So certainly in those situations, if not others, I think our California hospitals play a valuable role in helping to identify folks with HIV, ask them if they will consent to a test, properly identify them, and then every one of us is going to have to work together to figure out how to treat them, get them to a physician, get them to a clinic where they can be treated. So I appreciate your position. I'm going to be supportive of the bill today, because I do think this is an important issue, and we're simply going to have to work with the hospitals to make sure that we alleviate any burden that we otherwise require, because we need you to help us solve this public health crisis. Thank you, Mr. Chair.
Thank you. Senator Pan?
Yes, I'm curious from the Hospital Association, just to walk through the numbers, you're saying that you would estimate you'd only pick up, was it 18 cases in a year?
It's 2% of the math just turns out to be about 2%.
So 2%.
You said 18.
Yes, I did say 18.
18
it's 2% of the 1.6 million.
That's not 2% of 1.6 million.
Oh.
18 is not 2. I mean.
Oh.
Yeah, 2% of 1.6 million is significant. It's about 32,000. Yeah. Yeah, that's a lot different than 18. Oh. If you're saying it's 2% of all the admissions.
I'll go back and check my math.
Yeah, okay, all right. I just wanted to clarify it, because 18, I mean, all right, thank you.
Okay, any other questions from any of the members? Seeing no questions. I sympathize with, obviously, the hospitals. Nobody likes to have unfunded mandates, and, I understand that we have an ever-changing healthcare system, but also I just want to reiterate what Senator Hall said is you have an opportunity, and the reason why I'm supportive is because it's when they get admitted through the emergency room that when they're doing a blood test that you ask them at the time, and that's an opportune time because you're already going to be drawing blood. And so when I look at it from a perspective of overall policy in the state, any time we can catch, even if it's 18 or 32,000, that's still catching HIV, a patient that could potentially be treated, as opposed to if we don't catch them, then they become a much more expensive cost to the healthcare system along the way. So that's kind of where I'm looking at it. I can't answer your question with regard to the reimbursement. There may be instances, but again, I'm erring towards the side of more Medi-Cal patients, and therefore you're going to at least get reimbursed for it. So I will be supporting the bill. Is there a motion?
So moved.
So moved by Senator Hall. We're at, would you like to close?
I think between Senators Roth and Hall, everything that I was going to point out was said. The only thing that wasn't said was, I just want to make sure that everyone also takes comfort in knowing this, that I don't know where the unfunded mandate comes from, because both private plans and public programs do cover these testings. So it's not going to be an extra burden on the hospitals.
Well, the unfunded would be the uninsured, essentially, because they're not covered and then the hospitals have to eat it. So I get that part anyway. But
So with that, thank you very much.
Item number 7, AB 521, do pass to judiciary. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen? No. Nguyen, no. Hall?
Aye.
Hall, aye. Mitchell? Monning? Aye. Monning, aye. Nielsen? No. Nielsen, no. Pan? Aye. Pan, aye. Roth? Aye. Roth, aye. Wolk? Wolk, aye.
Thank you.
Thank you. That's 6-2. All the members that are here. Mitchell is absent, so that bill is out. We're at item number 9, AB 664, Assemblymember Dodd, Medi-Cal Universal Assessment Tool Report. Good afternoon, Assemblymember.
Good afternoon, Mr. Chairman and members. AB 664 would require a formal evaluation of the Universal Assessment Tool pilot program. California provides home and community-based services to low-income seniors and persons with disabilities to help them remain in their own homes and communities. In 2012, the legislature recognized that separate eligibility determination and assessment processes for home and community-based services created several forms of inefficiency in the administration of these programs. The Universal Assessment Tool was identified as an alternative to the current assessment system. This tool is a single application and data system that would streamline eligibility determinations and assessments. The goal of this new framework is to facilitate better care coordination, enhance customer choices and consumer choices, reduce administrative inefficiencies, and potentially create long-term fiscal savings. SB 1036 and SB 1008 from 2012 directed the state to develop a universal assessment tool to be pilot tested in 2 to 4 counties. However, it did not require a formal evaluation. AB 664 would require on or before January 1st, 2017 for the administration and stakeholder work group to evaluate and report to the legislature on the outcomes of and the lessons learned from the Universal Assessment Tool pilot program. Here with me in support is Karen Sewell on behalf of the California Commission on Aging and Randy Hicks on behalf of the California Alliance for Retired Americans. Thank you.
Mr. Chair and members, I'm Carol Sewell from the California Commission on Aging. The 2012 passage of SB 1008 called for development of the Universal Assessment Tool as part of the pilot program that shifted the dual eligibles into Medi-Cal managed care. While we look forward to the prospect of this Universal Assessment Tool being put to use next year, the Commission on Aging also sees the importance of an early evaluation to assure that the tool is working as planned. AB 664 establishes a clear timeline for that evaluation and guidance on the data to be collected, including consumer satisfaction and comfort levels with the evaluation, data on hospitalizations following use of the UAT, and a comparison between the levels of home and community-based services identified for a client versus under the previous assessment versus the home and community-based services identified using the UAT. AB 664 provides an opportunity for the state to evaluate the new tool at an early stage, enabling adjustments as needed to assure its effectiveness and value in helping to streamline access to the services that vulnerable consumers need. We ask for your aye vote.
Thank you.
Randy Hicks with the California Alliance for Retired Americans. We echo all the comments says. It also would shift the HCBS framework from program-based approach to a person-centered approach. The goal of this new framework is to facilitate better care coordination, enhance consumer choices, reduce administrative efficiencies, improve data analysis capabilities, and potentially create long-term fiscal savings. And so that's why in California Alliance we're in very strong support. Thank you.
Thank you. Anyone else? Opposition? Questions from the members? Yes, Senator Wolk.
I was going to say it's a good bill, time to move it forward, and my colleague who moved it, I'd be glad to move it.
We have a motion by Senator Hall, and would you like to close?
Just respectfully ask for your aye vote.
Thank you very much. We're at item number 9, AB 664. Chair is recommending support to pass 2 appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Nguyen, aye. Hall. Hall, aye. Mitchell. Monning. Monning, aye. Nielsen. Pan. Pan, aye. Roth. Roth, aye. Wolk. Wolk, aye.
Currently has 7, and I believe, oh no, we're missing, we'll put that bill on call. We still have a member absent.
All right, great.
So,
Thank
but
you all
it's
very,
enough
very
to get
much.
out.
Appreciate it.
Item number 10, AB 918, Assemblymember Stone, seclusion and restraint, developmental service, health facilities.
Good afternoon, Mr. Chair and Senators. Thank you. Before you is AB 918, which is an important bill that protects some of California's most vulnerable citizens. As we're moving from the clients from the developmental center out into more community-based settings, we need to make sure that we are reporting and understanding where seclusions and restraints are being used for the vendors of our regional centers. This bill closes that gap. The legislature's been very clear in the past in trying to ensure that we're not using restraints, we're not using seclusion techniques which are not therapeutic, not beneficial. And this is a bill that's meant to close that gap and ensure that the reporting is happening. It's not additional reporting for most of these facilities because they are already reporting. There would be additional reporting if there's injury or death because of a seclusion or a restraint scenario, but the normal reporting that they're doing through their licensing requirements would be included here. So it's not an additional burden on those facilities, but shines a light on the practice. And with that, we do have some witnesses in support, and I request your aye vote. Thank you.
Hi. Good afternoon, Chairman Hernandez and committee members. Thank you for the opportunity to address the committee today. My name is Leslie Morrison. I'm Director of the Investigations Unit at Disability Rights California, and we are the sponsor of this bill. As Assemblymember Stone mentioned, AB 918 requires that the Department of Developmental Services publish data they currently collect regarding the use of restraint and seclusion in community facilities. Disability Rights California brings this bill after family members of adults with developmental disabilities came to our organization to express concern about the lack of transparency on the use of restraint and seclusion in community facilities. As state facilities close, individuals with developmental disabilities are moving into the community, and it is essential that the public have access to information about the use of these dangerous practices. The data, as the Assemblymember mentioned, is already being collected. It's just a matter of the department publishing the data and making it available to the public. AB 918 also requires that facilities serving regional center clients notify the Protection and Advocacy Agency, which in this state is Disability Rights California, about deaths or serious injuries related to the use of these dangerous practices. And as developmental centers close and people with disabilities move into the community, it's important that we have public reporting and better disclosure about these practices. We ask for your aye vote.
Randy Hicks, California's Disability Rights and Mental Health Services client. I know what she talks about. I've seen it happen. I was in a facility in Iowa, and they used all kinds of seclusions and restraints, not necessarily physical restraints, but liquid restraints, such as medication or drug therapy, and it didn't always work. And they tried to use it on me, And they never looked out for what the side effects was to using liquid restraint. And so we should find out how much is being used, who's being used, and how the effect and the outcomes are working. So as a client and a member of Californians with Disability Rights, I'm in strong support of this bill.
Thank you. Anyone else? Opposition? Support or opposition?
Support.
Okay, please.
You can't see me, but
Okay. State your name.
Tony Anderson, representing the ARC and United Cerebral Palsy, California, in strong support.
Thank you. Opposition? Questions? No, seeing no questions from the members, there's a motion by Senator Roth. Chair is recommending support, and we're at item number 10, AB 918. Would you like to close?
I just asked for your aye vote. Thank you.
Thank you. And do pass to Human Services. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Monning. Monning, aye. Nielsen. Pan.
Aye.
Pan, aye. Roth. Roth, aye. Wolk. Win. Win, aye.
Okay.
Wolk, aye.
Currently has 6, enough to get out. We do have a member absent. We'll put that bill on call.
Thank you. Thank you, Senators.